Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations. And if you could turn those in, and particularly if you could give us any ideas that you might have in regards to future topics or future speakers, CME committee is always appreciative. Today we actually have co-presenters, Christine Sutton and Dr. Selden Spencer. Dr. Spencer is well known to the Grand Rounds audience here. He is a board-certified neurologist and polysomnographer and neurosonologist, and frequent and excellent contributor to Grand Rounds. Ms. Sutton is a native Iowan. She's a graduate of the U of I, and previously she was Vice President of Communications at the Iowa Medical Society and editor of Iowa Medicine. Subsequent to her husband's death in 2011, she has been a volunteer for the Greater Iowa Alzheimer's Association. She's the Alzheimer's ambassador to Senator Charles Grassley's office, and she's also a facilitator for the Boone County Caregiver Support Group. They're here today to update us on Alzheimer's and give us a caregiver's perspective, and please join me in welcoming Ms. Sutton and Dr. Spencer.
Can everyone hear me? Thank you very much for asking me to come and speak to you today. It's a real privilege to speak to this group. and to share my experiences as a caregiver for someone with Alzheimer's disease. A little personal background: Gary and I were high school sweethearts who went our separate ways after graduation and reconnected in 1999 at our 30-year class reunion. Like his father, who practiced family physician in Boone for 52 years, Gary was a family doc. His subspecialty, ironically, was geriatric medicine. He loved taking care of elderly people. He had a pretty typical, very busy small-town practice in Claremore, Oklahoma. And in 2001, I moved to Oklahoma, and Gary and I got married. In June of 2007, we moved back to Boone, and Gary had been hired to replace Jack Murphy, who was retiring from practice. Within 1 month, Gary was placed on leave because he could not learn the office computer system. And I learned later that one of the worst things you can do to someone with Alzheimer's is to take them out of their familiar environment and put them in an unfamiliar one. It has a tendency to make the symptoms come roaring to the surface. In October of 2007, a few months later, Gary was diagnosed with early onset Alzheimer's. He was 56. And for the next 3 years, I was his primary caregiver at home. Caregiving was the biggest challenge I've ever faced in my life. I hope I never face anything like it again. And I faced it at a time when I was struggling with grief and very deep depression over the fact that the man I love had been diagnosed with a terminal illness, and that I didn't know a lot about Alzheimer's, but I knew it wouldn't be a good death. Caregiving was physically, emotionally, and mentally taxing, and there was absolutely nothing in my professional or personal background that prepared me for it. There aren't any guidelines, there aren't any rules, and so what I did was just sort of put my head down and slogged from one day to the next. And just when I'd be all proud of myself for solving one problem, along came another one, even more challenging. Alzheimer's caregiving is feeling like no matter how hard you try, you're always going to be one step behind the disease. In a lot of ways, caring for somebody with Alzheimer's is very similar to caring for anyone with a terminal illness, only the added gift of Alzheimer's is that you watch the person you love deteriorate physically and mentally. So it sort of feels like it's very lonely, Alzheimer's caregiving, very lonely, and it felt like becoming a widow and a single parent all at the same time. There were days when I literally believed I wouldn't survive it. But, you know, this is your husband, and so I did it because I knew he would have done it for me. And on days when love fails you, you remember that you promised in sickness and in health. And then some days the sense of duty fails, and on those days I tried to think ahead of how I would feel if I had a life after caregiving. And I knew that if I would have a life after caregiving, I needed to be able to look back and say, I did it absolutely as long as I could. I did it until I didn't have a choice but to stop. So the experts told me that the Alzheimer's disease process actually started 25 years before the disease is in its final stages, which means that the destruction of Gary's brain ostensibly began when he was in his early 30s. But once the symptoms were externalized, it seemed like the disease just progressed so rapidly. And at the time Gary was diagnosed, no one was admitting the truth that I thought I saw every day, which was that early onset Alzheimer's is almost a completely different disease because it progresses so rapidly. I talked to doctors who had patients who lived 6 months after a diagnosis. I found an Alzheimer's scale that divided the disease into 7 stages and described the behaviors in every stage. I never could tell which stage Gary was in because usually he was exhibiting behaviors from all 7 stages simultaneously. But in all honesty, I would have to say within a year after his diagnosis, he was at least in stage 4 and possibly stage 5. And his doctor at Mayo told me to start looking into long-term care. And of course I said, he was just diagnosed a year ago. So what were our lives like at home? For the first 6 months, they actually weren't too bad, but I can only say that in retrospect because at the time I thought things were pretty bad indeed. My biggest challenge at that point was dealing with Gary's desire to help me. The hardest part for him was feeling useless. And you know, you physicians in the audience, you know how many hours you work a week. And all of a sudden to be at home with absolutely nothing to do. You know, 60-hour week was light for Gary. So he wanted to help me. He had a strong work ethic. And he still could complete simple tasks at that point, but even then, his short-term memory was almost non-existent. And there were some days when he literally, I know it's hard to believe, but asked me in the space of 2 or 3 hours the same question 25 or 30 times, worded in exactly the same way. His attention span even then was almost 0, and he had absolutely no ability to figure out an activity that he could do or keep himself occupied or pick up a magazine and read it. He depended on me for that. After about 6 months, things really started deteriorating. And he still wanted to help me around the house, but he was not capable of following instructions even for what I call the 2-step task, which I would say, okay, Gary, go down in the basement and get the vacuum cleaner and bring it back up. Well, he would go down in the basement, but by the time he got down there, he forgot why he was there and came up empty-handed. So he helped me by unloading dirty dishes from the dishwasher and putting them in the cupboards, and emptying the dirty clothes out of the hamper and putting them away in our dressers. I carried groceries in from the car, and when I wasn't looking, he carried them back out to the car. He wanted to mow, thought that was his job, and he mowed like it looked like crop signs when he got done, crisscross patterns. And so the long and short of it was almost everything he did created more work and more stress for me. Then he started doing very bizarre things, and I started learning the survival tactic of letting him do whatever he wanted to do as long as it didn't hurt. He would change his shirt 10 or 12 times a day. He put on multiple layers of socks. One day he had on 5 pairs of socks, those were difficult to get off. He ate raw meat out of the refrigerator. I didn't let him do that anymore. We had a couch pillow that had an embroidered picture of a West Highland White Terrier, and Gary talked to the pillow because he thought he was talking to our Westie, Lucy. This is a person who scored 99% on his first family practice boards. And he came out of the bedroom one day with 4 ball caps stacked, one on top of another. And my first reaction when he would do these things was just absolute horror, and I would run into the bathroom and cry into a towel because it upset him when I cried, and I didn't want him to hear me cry. But then, gradually, it was such a blessing. I got used to it. No matter what he did, I got used, didn't bother me. And after that, I even started to be able to see the humor in some of the things he did, and that was a true blessing. As Gary's dementia progressed, our lives got more and more isolated, and he couldn't be left alone even for 5 minutes. I mean, he did truly, turned on burners and things like that. Even going to the grocery store got to be an ordeal because he would continually wander away and try to talk to people and look at things in their carts. And believe me, not everyone reacted well to this. One day we were driving down a pretty busy street in Boone, and Gary opened his car door. So after a few incidents like this, it becomes a lot easier just to stay at home. And here I was my brain was okay, sort of, and but I was in this increasingly bizarre world, and I think the isolation of caregiving sort of dulls your perspective on things. And I'm sure somebody could have come in our house and said, this woman is drowning, but I just didn't think about it. I just kept going. Despite living for years with someone with Alzheimer's, the only absolutely one true thing I know about Alzheimer's is something one of Gary's doctors said to me. He said, when you've seen one Alzheimer's patient, you've seen one Alzheimer's patient. And I was blessed because Gary never did become belligerent or violent, even though they told me that this was inevitable, that he would. But he had other symptoms that I wasn't told about. One was anxiety, another was clinginess, and the other one was severe sleep disturbances. Because of the damage to his brain, Gary had no ability to soothe himself when he would start to feel anxious, and he had always had a tendency toward being somewhat anxious anyway. So the anxiety would start late in the afternoon, and it would just grow and feed on itself until it was just completely out of control. He would sigh, he would pace, he ran his hands through his hair, his hands shook, his legs shook, and he would look at me with just absolute anguish on his face, and it was so hard to watch. It was so painful. And at first I called it talking Gary down from the ledge, and I would talk to him in a very calm, soothing voice, and that seemed to help, and that would sort of bring him around. That didn't work after a while, so I started rubbing his neck, rubbing his back. The dog sitting next to him seemed to calm him down. And then sometimes I played his favorite music, and that was very effective. Gary developed a severe case of Alzheimer's clinginess almost from the time he was diagnosed. And, I was his anchor in a world that was, increasingly unfamiliar and frightening to him. But the end result was he followed me everywhere, all day long, even into the bathroom. He followed me, and then the dog followed him. So we were this little crate, sad little crate, going around the house. And when he wasn't following me, he was staring at me. And I'm not sure, maybe Dr. Spencer could tell the reason for that. But and then the dog started staring at me too, and she's still doing it to this day, unfortunately. But I asked the doctors at Mayo, and he said, nothing you can do about that, dear, and he told me eventually he'll stop, and eventually he did. But that was the behavior I never quite lived. It just really bothered me, and I couldn't make myself not be bothered. During the first year after his diagnosis, Gary started demonstrating physical manifestations of Alzheimer's, something I had not thought about, but your brain runs everything, right? Gary was an excellent athlete. I was with him in 2000 when he ran the Boston Marathon, but Alzheimer's made him extremely clumsy. He stumbled and tripped and he fell, something I'd never seen him do. As I said, his arms and legs trembled. He had, I called them seizures. I don't know if they were, but they were so violent in his sleep that he would fall out of bed. He dreamed that people were hitting him and he flailed around in his sleep. Many people sleep more as dementia progresses. Gary slept less. And this, of course, is eventually what did me in. I was always able to get him into bed, but there were many nights when he woke up repeatedly. And I just thought of it as his brain is just torturing him. I had trouble sleeping because of all the moving around and because I was afraid of what he would do if he got out of bed in the middle of the night, which he frequently did. The doctors started advising me to sleep in another bedroom because they said sometimes caregivers are seriously injured, and there were a few mornings when I woke up with a bloody lip. But I just couldn't give up what I thought was the last vestiges of a normal marriage, which was sleeping together. So we hit bottom in the fall of 2010, which was about exactly 3 years after he was diagnosed. He had long since stopped talking to me, and I didn't think he knew who I was. I was pretty sure. He started losing weight. Caring for him became increasingly demanding because I had to help him with everything. He began to be incontinent several nights a week, and I was so sleep deprived I felt like a zombie. A lot of my memories of that time are kind of murky. It's probably good. So with the help of Gary's neurologist, we tried several different sleeping medications, but none of them worked the way they were supposed to, because I guess they're tested on people with normal brains, right? So, and in fact, one of them made things worse because it increased Gary's urge to urinate, which made him wake up even more often. After the third sleeping med failed, they said, there isn't anything left to try, and you'd better place him in long-term care or you're going to be seriously ill. So, and other people were advising me to put Gary in long-term care. But I knew instinctively that I couldn't let someone else make this decision for me. I couldn't have this be a decision I made because I was bowing to someone else's will, because they wouldn't live with the decision. I would. And no matter how bad things got, I struggled to accept that, that I'd reached the end of my rope and that there wasn't any further to go. And I've spoken to a lot of caregivers, and this feeling is absolutely universal. Guilt, regret, sadness. And I still sort of wish I could have kept him home until the end, but logically I know I didn't have the tools to do that. Gary looked, he always looked younger than he was, and he looked ridiculously young in the nursing home. My 96-year-old aunt was in the room across the hall from him. And to this day, I don't know where I got the strength to turn around and walk away and leave him there that first time. I knew that it would be a bad transition for him because, any change for an Alzheimer's patient is so traumatic, and it was. The good thing is he thought he was there to make rounds, something he'd done hundreds of times, and they gave him a clipboard. The bad thing was he didn't sleep for 76 hours after I took him. It felt to me like it was the end of our marriage, the end of our lives together, kind of like the end of my life too. But it's such a mixed feeling because at the same time, you feel absolute relief because it's like an anvil is lifted off your shoulders because the care is no longer, burden of the care is no longer yours. And I went home that first weekend, and I slept the clock around, and I did that for about a week. By late December of 2011, Gary had lost 40 pounds. He could no longer talk, he could no longer walk or even stand up. And he developed a urinary tract infection, which, according to his wishes, which were very unequivocally stated, we didn't treat it. And the infection, of course, turned septic, and he died December 24th of 2011 after 15 months in the nursing home. So what did I learn about caregiving and Alzheimer's? Alzheimer's caregiving is so difficult that I can't imagine lasting very long at it without some kind of support system. A solid support system and local resources can raise the quality of life for an Alzheimer's patient and delay the time when the patient enters long-term care. Based on my experiences, I believe it's of paramount importance that caregivers know exactly what resources are available locally before those resources are actually needed. I believe every Alzheimer's patient and caregiver should leave the doctor's office with two things: a definitive diagnosis and a care plan. Caregivers need to know that professionals are available to help when the inevitable crises arise. When Gary went to the nursing home, I made an appointment with our family physician, Paul Boker, and we spent an hour discussing every possible scenario for how Gary's life would end and how we would handle each one of those scenarios based on his wishes. I can't say it was the most enjoyable hour I've ever spent, but I'm really glad we did it because we had the plans in place ahead of time, and that made me feel better. And also, when there were other family members there and everything was coming apart, it helped me keep sight of what my husband said he wanted. Experts say caregivers need at least 6 hours a week when they're completely free from their duties. But according to the Caregivers Association, only 20% of caregivers actually get that time. A dear friend of mine would come every Thursday afternoon, took Gary out for a long drive and to get ice cream. And I had 2 hours where I could do whatever I wanted. You can't imagine how much I look forward to that time. There's no, as my video said, there's no effective treatment for Alzheimer's, and many of the medications prescribed for Alzheimer's behaviors don't work the way they're supposed to. So in the absence of those two things, I think there needs to be a lot more emphasis on behavioral therapies to deal with the symptoms of Alzheimer's. Pet therapy, touch therapy, music therapy, all of these things can increase the quality of life for the Alzheimer's patient and their caregiver. Funding for Alzheimer's research has to be increased. I mean, we are spending so much on the back end of this disease that it just doesn't make any sense. And with 78 million baby boomers living longer and the incidence of Alzheimer's increasing, this one disease alone has the capacity to sink the long-term care system. One thing I learned was that just about every notion I had about Alzheimer's was false. A lot of people told me, you know, Chris, at the end of this, it's going to be way harder on you and the other people who love Gary because he won't know anything at the end. But I have two brief stories that I think that demonstrate why I don't really believe that anymore. One of Gary's faithful visitors in the nursing home was one of our classmates at Boone High. He was the quarterback and Gary was center on, we had a championship football team in 1968, CIC champs. And he was one of Gary's friends who was a very faithful visitor and brought him ice cream every time. And this was the first time that the Eagle's Nest from Decorah was being streamed live, and they had this on a monitor. by the nurse's station, and Gary and Roger were sitting there eating their ice cream, and Roger said that after about 10 minutes, Gary said, "I gotta say, this is the worst TV program I've ever seen." And that made me laugh a lot because it was very typical of Gary's sort of wry, kind of understated sense of humor. But then later I thought, what, he can't even talk. Where did that come from? And a lot of other caregivers have told me the same thing, that, you know, the dementia is very advanced, and all of a sudden they'll turn around and say something to them that's just shocking. It's so much like they used to be. The other story involves the issue of whether or not Gary knew who I was, and this is something I'm asked about frequently. And as I said, for about the last year of his life, Gary had not said my name to me, and I was pretty convinced that he didn't know who I was. But 1 month before he died, Thanksgiving, my daughter Kelly was, excuse me, my daughter Kelly was home, and she resembles me. Well, actually, she looks like I think I look until I look in the mirror. But she looks like I looked when I was younger. And she went to visit him, and she came home and said that as soon as she walked up to Gary's chair, a huge smile broke out on his face, and he said, "Christine." So this was just a wonderful gift for me, because I knew that he did remember me. He hadn't forgotten me. He just remembered it differently. But I think these stories prove all over again how little we know about Alzheimer's and about the human brain. On a personal level, I learned, oh boy, it is absolutely true. Your life can change in a heartbeat. And I also learned that the only security in life is whatever inner strength you have that you can draw on. The most important thing I learned is that the healing process can't begin until you learn how to find meaning in a tragedy like this, and how to make something good come from it. So that's one reason I wrote a book for caregivers, because I feel sort of like I'm carrying on Gary's work in a different way. But I'm also looking for something good. And every time I, talk to a caregiver, or someone says, "I passed your book along to a friend whose husband has Alzheimer's," it really does make Gary's death seem a little less meaningless. That's all I have. Dr. Spencer, do you want me to take questions now, or should I wait? It's 12:43.
What's the sense? Anybody want to ask a couple questions right now?
Okay.
All right. We'll have time, maybe.
Okay.
Yeah. Thank you very much. So yeah, it's 12:43, and I told Dr. Hallberg that I can squeeze this in 15 minutes or drag it out to 30 minutes, and looks like I'll work with the 15 minutes. And thank you again, Christine. It's a very powerful presentation. I heard it before, and that's why I recommended this to the committee. As a doctor, you see patients, and we talked about this before, that it's very important that we pay attention to the caregiver, because they're the ones that are really suffering, we think. Okay, so this is going to be intellectualizing the painful subject that we just heard about. And I'm going to kind of start here as a tale of two brains. On the left is Augusta Dieter, who died at age 51, 1906. This is the index case of Alzheimer's disease. This was a woman who survived for 5 years. And Alois Alzheimer, who was a psychiatrist in Vienna, had the privilege of a stain called Congo red, had her brain and put the Congo red on the brain and identified a peculiar peptide, and that is the amyloid. And that has been the subject of all our investigation and talk about Alzheimer's disease forever. This is a different brain over here. This is George Bishop. He was a neurophysiologist at where I trained at Washington University, and he had died probably about, well, literally 7 years before I started there. And the reason I bring him up is his lab was part of a Nobel Prize winning discovery about neurophysiology action potentials. So this guy was no dummy. He carried a lot of weight. And to anybody's knowledge, he was perfectly fine until he died of a heart-related condition at whatever the ripe age of 83 or something like that. But on autopsy, his brain was loaded with amyloid, just loaded. So in my training, whenever the subject of Alzheimer's came up, it was always about, well, you know, we got to get rid of the amyloid, and then we all kind of roll our eyes and say, well, maybe amyloid doesn't have anything to do with anything. And so that's going to be some of the subject of this talk is, what do we do about amyloid? So I'm going to go over some old things first, and I'll blow through that pretty quick, and then I'm going to talk about a lot of new things toward the end. So we always have to talk about other conditions that may not be Alzheimer's disease, and they're interesting. Just if you think about multiple sclerosis, people get very demented from multiple sclerosis, an immune-related problem. And so we have these definitions, and I always want to emphasize that dementia is the impairment of function. When are you no longer able to act independently? Mild cognitive impairment is a very flexible, useful, in my mind, construct. People say, geez, I'm just not thinking that well. I'm just not remembering that well anymore. And yes, they are making mistakes, but they're not functionally impaired. And we'll talk about that a little bit more. But basically, one of the questions that's going to come up is, what is normal aging? What is not normal aging? What is pathologic? And an example of that was just about function. This is the case I had. She came in with a mental status testing showing 23 out of 30, which is pretty bad. This on paper sounds like dementia. She came back to see me in 2012, having moved in with her daughter, and she scored very well, 20 out of 30. So she didn't get worse. She got better. And there was a question about her alcohol use, and she got her obstructive sleep apnea treated. So it's something you have to kind of keep flexible about. Mild cognitive impairment, this feeling that I'm not remembering things and I'm forgetting things, is, as I said, pretty fluid, and we think, 10% per year go on into a dysfunctional state of dementia, but it can reverse. Alzheimer's, these are the grim statistics. I think the one I like to emphasize out of the grim statistics, it's the only major disease category that's increasing of medical problems, and we haven't a clue of what to do about it. This is the Dr. Oz presentation, and this is the Alzheimer's brain, and this is the healthy brain, and you can see quite clearly that it's smaller, and an area called the hippocampus is shrunk up badly, very important for memory. But now I want to kind of just throw it on, if you look at healthy 90-year-olds without any evidence of dementia, that is autopsy series of them, they will all have that structural characteristic. So the structure per se does not correlate to function. And on pathological studies, half of normal 90-year-olds who live to that age have the pathological hallmarks of Alzheimer's disease. So it's a little unclear what's going on. So yeah, you can do amyloid staining, and you can see a normal person doesn't have any amyloid, but people with Alzheimer's usually do have a lot of amyloid. And likewise, you can see that a normal person has a lot of metabolic activity around the surface in their cortex, but as they diminish in their cognitive abilities, it gets worse. And so this is the Congo red collection of amyloid right there, all over the place. And you see also these clusters of cellular debris called tangles. And these are the cartoons that I've lamely shared for 20 or 30 years. You get amyloid and it kind of sloughs around the outside of the cell and kills the cell, and then these little fibrils become the tangles that we see later on. And it's some kind of, we think, miscleavage of the amyloid precursor protein. And so a lot of time is spent, well, what can we do to alter the enzymes so they don't cleave this way and then get out there and cluster and kill the cell? And of course, we've already talked about the idea that you collect the amyloid and then the cells start to die and then the person doesn't function very well. Problem is, you can have dementia without amyloid. That does happen. And it's really not clear how this is the bulk composite theory, but it's not perfect. And the problem with the theory is that you can get rid of the amyloid and it doesn't make any difference. The person is still going to be demented. And you can have cell death and dementia without amyloid. And there's all these little peptides, amyloid, PDP, 43, tau, even alpha-synuclein, which is key for Parkinson's disease, that really probably have a different interpretation in brain function. Furthermore, there's suspicion that some of these peptides, amyloid, spread like prions, proteins, throughout the connectome. And I should talk a little bit about the connectome. But here's a story of a patient I saw just recently who fell down and was brought into the hospital. And because of that, they were worried about a stroke, and they got an MRI of his brain, and his brain is terrible. There is tremendous volume loss all around. There's ischemic damage, but this is a diabetic, still measures his own blood glucose, administers his own insulin. So there's variables in cognition, and this is a slide meant to confuse. But the point is that you have structural problems out here, but then there's something called cognitive reserve out here that is not measured by looking at the tissue. So you got to know a little bit about the connectome. That is, you have networks of neurons. They rise together and depress, and they play key roles, whether you're playing tennis or whether you're trying to remember or do calculus. They have connections or networks that they work together, and Alzheimer's may be a network disease. This is the network that's functional for memory and cognition in Alzheimer's, including the prefrontal cortexes, the precuneus, and the hippocampus, really key. And those are the ones that get trashed in Alzheimer's disease. And now there's been some evidence that the prefrontal cortex is what's really key for the whole idea, of cognitive reserve. So I just want to bring out some other ideas: vascular issues, neuroinflammation, infection, aging gone bad, neurodegenerative disorders, or just disorders of our innate immunity. And amyloid beta peptides are actually good things. They're entrapping microbes, and there's evidence. But traditionally, I see somebody with cognitive problems, and we want to get an MRI, look at their brain, and I don't feel comfortable using the term Alzheimer's disease when you have so much tissue damage that looks ischemic. And we were talking before this, the radiologist will say evidence of subcortical injury. And that's a lot more complex than that phrase. And what's normal? What's normal? I don't know. But anyway, there are some things that we talk about in terms of small blood vessel disease, and I'm particularly interested in the this isn't what I was looking for, but this is the vascular dementia, which is easy. Yeah, sure. Somebody comes in with a hemiparesis and they can't remember anything. Well, yeah, maybe this is more stroke related. I understand that. And if they don't have any focal signs, if they're using their arms and limbs and vision perfectly fine, then maybe it is more like Alzheimer's disease. Maybe I should go back here. If you lose a chunk of tissue out here in the triangular chunk taken out of the large vessel occlusion, that is more comfortable for vascular dementia. But I think this also counts as playing a role in dementia. Yeah, so here's a case, another case, and I would challenge you to look at, I'm supposed to use a mouse, maybe I'll use the mouse here. Yeah, okay. So you see these little spiculated areas here. This is vascular damage. you look at this tissue damage down here. It's not the same as up here, but that's vascular damage. You can do the gradient echo, and you can see these blops of blood, and that's not the same as the other two. So there's interest now in trying to look at a variety of different small vessel diseases in Alzheimer's disease, or in dementia, I should say, and to grade them. We've always heard about arterial sclerosis, which is more diabetic and hypertensive, a thick wall in the small blood vessel, getting worse and worse. But you also get this vague kind of myelin loss to the point that there isn't any white matter functioning there at all. A lot of different varieties. And certainly if you get amyloid in the vascular wall, that ain't good. That's bad. All right. So here's the money slide. This is what you came for. This is it. The idea is when you get older, the blood vessel, for a variety of different reasons, doesn't work, and it leaks. And junk gets into the intracranial, or the brain, and can cause mischief, including amyloid production, which is probably trying to protect the brain. And so you get these ideas, and this is also kind of a money slide. The idea is you get old and you don't work so well, particularly in terms of processing metabolic elements, and you get normal aging, and it gets a little worse. But some people, it gets worse, and they get a lot of junk up here, and they have worse cognitive function than a normal person. Just to kind of give you the kind of concept that Alzheimer's may be more just a dysfunctional aging process. Lots of vulnerabilities. Take one. Could it be genetic? Could it be immune? Could it be the lysosomal thing, which is emphasized in the previous slide? Take your pick, and maybe it's a collection of some of these. I got one more variable that I can throw in there later on, but here's my theory. You have bad arterioles that leak. You get bad bugs or toxins in the brain. You get neuroinflammation. Amyloid is produced to protect. Amyloid is insufficient or not cleared out, and neurons die, and you get the tau fragments, and the tau spreads like a prion, causing more trouble. So you get bugs in the brain, and this is the prion argument that's been out there quite a while, starting in the hippocampus, spreading north into the precuneus, and then into the frontal cortex, and mild cognitive. Anyway, that's ongoing theory, and there's some support for that. That's the word of the day, NanoNet. Anyway, I thought this was really very original. That's my computer skills showing up there. No, that of my staff, I should say. The idea is that amyloid collects to surround a microbe or microbial element or a toxin or something like that. And I hadn't heard the word, so I threw it in there. Right. Okay, so one element, last element, and this is a little tip of the hat to the committee and to my colleagues. Larry Ottoman came up and shook me about the whole idea of glymphatic system, which is now very popular, which is the clearance of stuff from the brain. And who's to say that Alzheimer's and cognitive impairment is not a dysfunction of our ability to lymphatically clear our brains, right? So the glymphatic system is kind of graphically shown here, allows it to collect junk in the intracranial system and along with the venous system drain it. And you can image it potentially. We are not doing that. And here's your bonus question. What is the one activity where your clearance system is optimal in your brain? Sleep. Yay, you got it. So sleep is the one condition where you really clear the junk out of your brain. So just the old motto is sleep is good, right? And so this is just a prettier picture of the glymphatic system. So many ideas in terms of treatment. You have many potential problems going on here, genetic being emphasized there. But so how do we treat? How can we help? The cognitive reserve is highly dependent on educational attainment. Christine, I don't know what to say. You know, obviously Gary was a very highly accomplished person, but in general, preventive the further you go academically, the less likely you're going to have cognitive problems later on. There is ways of preventing. This is a study from Finland, but there's a study from UCLA and USC where if you do intensive treatment, whether it be dietary, whether it be exercise, whether it be all these other ideas, you can see improvement. You can see improvement in processing speed. You can see improvement in executive function. You can see improvement in complex memory. So there's a plasticity here with which you can work on, but it doesn't address the underlying problem. And so I think the cure is still exercise. And to that end, there's innumerable markers in terms of your vascular system, whether it be carotid stiffness or blood pressure variability, your heart rate, that predict or have a bearing on your cognitive performance. And then this is the last bit, which this is the reference here. This guy is in Stanford doing some weird stuff, basically taking young blood and putting it in old people. And I was telling Steve before coming here, I can vouch for this. I've had patients who get on IVIG, I'm sorry. IVIG on a regular basis because of a vague kind of an immune neuropathy, and they do great. Young blood is good. And, you know, it's kind of the old Dracula vampire theory of life, but there is something in young blood, which in these experiments, they document that taking young blood, putting it in old rats, turns them around. They get better. A little scary. All right. There are some drugs that are FDA approved, and I'm not going to dwell on those. We've already kind of addressed. They're out there. You can try and use them. And this is kind of my conclusion. Exercise, active, complex diet, and that's it. So did I make it? Almost. Okay. So I'm happy to stick around. And Christine, would you come and join me here? And if there's any questions, please jump in. Oh, okay. I'm sorry. I had a couple slides about turmeric, and this is a great, almost a joke, because there's a big article from a journal that we all read, which is the Indian Journal of Public Health, which showed that the incidence of dementia is much less in India. And furthermore, they subcategorized their population in India, and those who ate curry had less dementia than those who didn't. So that's the rage now, is to promote curry and turmeric. But I don't think, and then, you know, there's some cellular studies that show that turmeric has a benefit in terms of neurogenesis. You'll see more neurons produced, and so there's things of that sort. Yes?
I have a question for our guest, Christine, right?
Yeah.
Yes.
So I don't want to seem too indelicate, so I'm going to give a little preamble, but roughly 20 years ago, I watched my grandmother decline with Alzheimer's, and you know, she went from this very, you know, accomplished artist to a really babbling pile of humanity that died a really tragic death. And you know, while she was still with it, and we were all kind of talking about her decline, she, you know, was pretty clear that she didn't want to, you know, die some embarrassing, terrible death, and yet that's what happened. And now my mom's starting to do the same. And I know she doesn't want the same either. Do you think we as a society need to talk about the place for euthanasia with diseases like this?
Yes, I definitely do. Gary, of course, being a physician, knew exactly what was coming, which made his courage even more remarkable. But the day he was diagnosed, he looked at me and said, "Don't feed me." And I had no idea what he was talking about. Later on, I understood. And I said, "What do you mean, don't feed you?" And he said, "When I can't pick up a fork and put it to my mouth, that's it." Now, do you think anyone in the healthcare system would go along with this request? No. But it was what he wanted. But still, they fed him. And at one point, he grabbed somebody's hand and pushed it away. But so he was facing what a lot of other people couldn't. And I absolutely think people are too afraid of this topic. When I talk to people who are caregivers and their person they're caring for doesn't even have a living will. I mean, and I say, well, have you thought about what are you going to do if he goes into a health crisis? You know, are you going to call 911? Well, I haven't thought about it. Well, yeah, I guess, you know. So there needs to be a lot more conversation about this, because with Alzheimer's, how's it going to end? I mean, you know, there's no doubt how it's going to end. It's not like there's a hope it's not going to end this in a certain way. So you've hit on a really important topic, and I think in a lot of ways we're kinder to our pets than we are to our family members.
Chris, would you talk about the title of your book and how you got it? I've read it, but maybe others don't know.
Yes, it's called Stop and Smell the Garbage. And the reason for the title is because Gary and I, we went for a lot of long walks because it was a huge stress reliever. And we were walking our dog, and I had her because Gary was past the point where he could handle the dog. And we passed this garbage can, and Lucy pulled me over to it. You know how dogs are fascinated with garbage cans. And I said, oh, are you going to stop and smell the garbage? And Gary went walking up to that garbage can and took off the lid and went. So that was the day I really realized how literally Alzheimer's patients can take you. And I thought, well, if I write a book, I'll have a chapter of funny things, and that'll be in there. And then I started thinking, no, there's a deeper meaning to that story. So that garbage can, which is I still walk by 4 days a week, came to symbolize looking for something positive when life dumps a pile of garbage on you.
I just had a quick question. So, because of being so young, did you have a lot of denial stage? Like, is it hard for you guys to tell family and friends? It's like my mom's not that much. She was 60, so living with it, but they're still in denial. Don't want to tell people even though she's symptomatic.
Yeah, I was in denial. Gary wasn't ever, but I was. And people have asked me, when did you realize he had Alzheimer's? And I say, when the neurologist told him he has Alzheimer's. That's when I realized it, although I looked in retrospect. And in my book, there's a lot of samples of things I thought of in retrospect that weren't normal, even though Gary was known for being absent-minded. These things, when you put them all together, they weren't normal even for him. But yeah, I was in complete denial. Well, why would I have, your 56-year-old husband becomes scatterbrained? Your first thought is not, oh, I bet he has Alzheimer's. Especially there was no Alzheimer's in his family. And his first diagnosis was pseudo-dementia due to stress. That was the first diagnosis.
Here's a question for Dr. Spencer. So 30 years ago, they convinced us, as the drug veto people, that we're to use hydrogen, so we gave it to everybody. Later they found out it didn't work. Now we're using Aricept and Amenda for everybody. Christine had a slide at the beginning that we don't have any treatment for prevent progression of dementia. Are we really doing anybody any good?
No, I think the argument, and I do believe the data on this, that the use of the acetylcholine receptor inhibitors prolongs the time they stay at home. That's the only data that I find very convincing. As far as any kind of tissue or a reduction in amyloid or anything like that, no, it doesn't do anything.
Gary was on both of those.
Yeah, so it's the idea that it might enhance the performance of the brain. That's what you're trying to get with those drugs. And unfortunately, you're not touching the disease. And my attitude toward it is, let's try it. If you want to try it, let's give it a couple months. If you think it's doing some good, that's great. If you don't think it's any good, let's let it go. Okay, I think we got it. Oh, wait. You can talk to me later, Jay, whatever.
I was going to wait for them to hand me a microphone and say I forgot.
But thanks. That's it. Well, thanks again. Take care. We'll see each other again somewhere along the way.
Yeah,
I'm sure.
probably will.
Yeah. Yeah. So.